Once again, we are charging tonight, and Dr. Islam Shehata is one of our colleagues from Ain Shams University Hospital. He is one of those talented people. He is assistant lecturer of anesthesia, his special interest in cardiothoracic anesthesia. Dr. Islam will introduce a lecture with a very interesting case report, lung isolation with vocal cords implant.
Yeah. I have no conflict of interest, so I think I can start immediately. I'm going to start with our case report in the Journal of Cardiothoracic and Vascular Anesthesia entitled Lung Isolation in the Setting of Vocal Cord Implantation. Our patient was a 70-year-old man presented for a video-assisted thoracoscopic resection of pulmonary nodule. He had a history of neck injury for which he had undergone vocal cord medialization with a Teflon injection to fix a left vocal cord paralysis. Teflon material has a common complication by forming a granuloma. So this procedure followed by debulking of the Teflon granuloma and placement of silastic implant. The preoperative bronchoscope showed complete left vocal cord paralysis, and this is the silastic implant in the left vocal cord. The glottic gap is not that narrowing, and otherwise the anatomy is normal. So we are going to isolate the lung for resection of the pulmonary nodule. I think it seems doable. You just should insert your tube, either a single lumen tube or double lumen tube through this hole. But I want to present this case from 2007 about a late displacement of Montgomery. Montgomery is one of the material of the vocal cord implant, as we will know. Late displacement of Montgomery thyroplasty implant following endotracheal intubation. And this should raise a medical legal issue, because if you hit the implant with the tube during the intubation, the patient will lose his voice. And not just the voice, as we can see, this is migration or displacement of the implant which obstructed the airway. So it's not that easy. This patient, after intubation, following what's called the revision medialization laryngoplasty to restore his voice again. So it's not that easy issue. What are the vocal cord implants? The indication for vocal cord implantation is the vocal cord paralysis. Causes of vocal cord paralysis may include surgical, neurological, traumatic, as in our patient, or neoplastic causes. The history of management for vocal cord paralysis started at the start of our century at the 1911 by injecting the vocal cord with material started with paraffin, then Teflon, as in our patient. They inject this material transcutaneous with help of endoscopic visualization. The philosophy of injecting the vocal cord is just to increase the size of vocal cord. So if you increase the size, you may decrease the glottic gap. Then medialization thyroplasty became the gold standard. So what's the medialization thyroplasty? It was introduced at 1974 by Dr. EDAIC. What he did is insert, as you can see in this video, this vocal, this is a paralyzed vocal cord. So there is a hoarseness of voice. He go through the skin to open the thyroid cartilage. Then make a window through the thyroid cartilage. Remove it. Then put an implant just to push the vocal cord. So the medialization thyroplast is called the medialization. It will push the paralyzed vocal cord to be medial, to be to to the other side, to the other vocal cord, so decrease the glottic gapping. The materials include Montgomery, titanium, and the handcrafted silicone and the layered Gore-Tex. This is very important to know, to remember it. Layered Gore-Tex. The philosophy, as we said, to reduce the glottic gapping. How we provide anesthesia for this surgery, I mean medialization thyroplasty, it's by local anesthesia infiltration for the skin. And you can provide sedation, or if the patient is not cooperative, you can just put a supraglottic device. It's very important to know the different material which used for injection or medialization thyroplasty, because they are different according to the stability. The titanium is the more stable than Montgomery, but silicone and the Gore-Tex both are not stable. Why? Because if we can see here, this is a Gore-Tex implant. As you can see, it's sheets, layers. So it's very easy to migrate, to be displaced and encroach on the airway itself. This is titanium or handcrafted Montgomery implant. As you can see, it's one piece. The surgeon crafted with his hand and put it through the thyroid hole or the thyroid window, thyroid cartilage window, to push the vocal cord against or toward the other vocal cord and decrease this glottic gapping so the patient can restore his voice. What about the preoperative airway assessment for patient has a vocal cord implant? It's all about the multidisciplinary team. You need a laryngologist for performing the preoperative bronchoscope, and he should attend the surgery, because if in case of displacement or migration, he may do what's called revision medialization thyroplasty, so the patient will be discharged from the OR with his voice. You will need airway expert anesthesiologist, because he can manage this airway and may deviate if he could deviate the tube away from the vocal cord implant, so he is not gonna hit this implant. And finally, the airway specialized radiologist to give you the full data about the implant and if there is any complication. It's very important to obtain a history of the implant. The type, as we said, Montgomery titanium has more stability, but silicone or the Gore-Tex are less stable. The duration of the implant, if it's recent, for sure the risk of displacement will be more. And the complication, as in our patient in the case report, he had granuloma after Teflon injection. So the surgeon replaced it with silicone implant. Finally, visualization of the vocal cord implant. You should, the unanticipated difficulty in this case is not allowed. So you should ask for preoperative flexible fiber optic laryngoscope to document the status, to visualize the implant, visualize the vocal cord, and if and the CT neck may provide a characteristic appearance of every implant. So if you do not have a history, the specialized radiologist may tell you, I think this is titanium. No, it's a layer, so it's a Gore-Tex. And for sure, just as we mentioned, will guide you during the airway management. The most important is to use what's called best fit endotracheal tube. The best fit endotracheal tube, it shouldn't be too small, so the airway resistance will occur. Not too large, so it will not hit or displace the vocal cord implant. And the most important here that all of anesthesiologists use the internal diameter to call a tube. If I ask for a 7.5 millimeter tube, it's the internal diameter. But the issue here is about the outer diameter, and it's for sure it's much larger. So, you know, in this nice photo about the 6 endotracheal tube, it's a 6 millimeter internal diameter, but outer diameter is about 2.8 millimeter larger. So it's very important to measure the internal diameter of the trachea. So yes, if yes, there is a room for 7.5 millimeter internal diameter tube. No, there is no. It will be a little bit narrow. How we can measure the internal diameter of the trachea as an anesthesiologist? We can use the neck ultrasound or ask the radiologist within the multidisciplinary team to measure it with the CT neck. Why we do all of this? Because there is a potential damage for the vocal cord and the implant with the endotracheal tube. They after the implantation, they studied the vocal cord and found that by the MRI showed there is a reduction of the medial to lateral dimension on the vocal cord. I mean this one. This is the vocal cord. It decreased in the from medial to lateral dimension. In another way, there is a stretch of the coronal plate. Now your vocal cord is not the normal vocal cord. It's stretched and thinner. So the injury with intubation will be more or will be higher. So the general airway management in such patients with vocal cord implant, that no airway device is better. If you can perform the regional, perform the regional. If you are gonna handle the airway, use the supraglottic devices. It's away from the vocal cord implant. If you are gonna put endotracheal tube, I think reinforced tubes may be more traumatic. We talk about the lung isolation. So as Dr. Khaled said, the options of lung isolation either be a double lumen tube, and this is the different fiber optic views for double lumen tube, and bronchial blockers. You can put single lumen tube and insert a bronchial blocker through it. The most recent one is the ACE blocker. ACE blocker may provide alternative one lung ventilation as does the double lumen tube. Simply, there are two balloons. You just insert this wide bifurcation here above the carina. Inflate this one, you will isolate the right lung. Inflate this one, you will deflate the left lung. But it's all about suction, no fiber optic. So everything has like cost benefit ratio. So the lung isolation may be double lumen tube or single lumen tube. Within it, we can insert the ACE blocker or another bronchial blocker. For sure, the single lumen endotracheal tube with the smaller outer diameter has less potential risk for hitting the vocal cord or display the vocal cord implantation than the double lumen endotracheal tube. As we said, laryngeal mask airway, tracheostomy are away from the implant. So if you choose between a bronchial blocker through single lumen endotracheal tube and double lumen has a higher potential risk. Is there any difference? Yes, this is the systematic review of about 39 RCT comparing between the double lumen tube and bronchial blocker found that the quality of deflation may be same with less post-operative hoarseness of voice for the bronchial blocker, and this may indicate that it's less traumatic. They are less traumatic. They are less coming in contact with the vocal cord. And for the main advantage of the double lumen tube is the shorter duration. Now coming to the intraoperative management. Our recommendation as our experience, as regard our experience for the case report, that we should use video laryngoscopy. We should use single lumen with bronchial blocker, or it may be safer to use single lumen tube with bronchial blocker than double lumen tube, as we mentioned. The endotracheal tube should be more than 7.5 internal diameter, so you have a room for both bronchial blocker and fiber optic bronchoscope. The airway specialized anesthesiologist may direct the endotracheal tube away from the implant or the paralyzed vocal cord, so it will be less injurious. Smooth induction during intubation to avoid coughing and bucking. And finally, and the most important, is the cautious inflation of the endotracheal cuff. There are two types of endotracheal cuff. The standard is the high volume. In this nice study, they studied the outer diameter and shape of the tracheal tube cuffs in pediatric population and found that most of us just push 3 or 5 mil of air in to inflate the endotracheal cuff, but it may be injurious away from impeding on the tracheal mucosal perfusion. In this study, they found that if you fill the syringe with too much air, increasing the pressure and volume, the volume of this cuff may increase up to 2 times the internal diameter of the trachea. So you will distend the trachea, you will push the trachea more and more, and this may threaten your implant. So please be cautious during inflation of the endotracheal cuff. About the tracheal extubation, it should be smooth up to deep extubation. If your patient is not full stomach, if it's not difficult intubation, deep extubation will be good. So there is no bucking, there is no coughing, and the most important is that to check the implant. If you haven't time to do all what we did, please do not forget to check the implant after extubation. How we can check the implant? We have two options. If you just wanted to take your tube out, introduce nasal fiber optic and withdraw your endotracheal tube out under visualizing it with the nasal fiber optic. If you do not have, if you do not need to make an injury for the nose with fiber optic, you can replace, as we all do. You can replace the double lumen or single lumen tube with supraglottic device, laryngeal mask airway. And after putting the laryngeal mask airway, introduce your fiber optic through it to check the implant. Yes, it's in place. No, it's not. It's not in place. It's displaced or migrated. Ask the attending laryngologist to fix it. The special situation, first is the emergency intubation. You are confronted with this patient in the ER, and there is no time for preoperative flexible bronchoscopy. There is no time to check the internal diameter of the trachea. Just use the video laryngoscopy. The importance of video laryngoscopy that you can see the whole vocal cords. You can you may see the implant. You can push your tube away from this implant. If you don't have video laryngoscopy, use the conventional laryngoscopy for the sake of emergency, but do not forget to check the implant after extubation with attendance of laryngologist. In case of difficult intubation, please do not use the bougie or endotracheal tube introducer, especially blindly, because it's very traumatic. Difficult intubation. Can we use video laryngoscope? Yes, you can use video laryngoscope with equivocal competency like the fiber optic bronchoscope. But the most important thing, the fiber optic has what we call a blind spot. This is RCT comparing the video laryngoscopy versus fiber optic bronchoscope for awake intubation. They comparing both of them in difficult intubation and found that video laryngoscopy may be a good alternative, a competent alternative for fiber optic bronchoscope even in awake intubation or difficult airway. So you can use it in the difficult airway. But why we do not advocate using the fiber optic bronchoscope? Because of the blind spot. I mean, here you can see this is the single lumen tube. This is the bronchial blocker, and this is fiber optic. And you railroad the endotracheal tube through the fiber optic. Fiber optic will give you a very excellent vision of the carina. But here, outside the endotracheal tube, where the implant exists, it is blind, totally blind. So the fiber optic has a blind spot outside the endotracheal tube where the implant exists. Now, what are the options? As we said, use the video laryngoscope. No, it's very difficult, and I want to use the oral fiber optic, awake or sleep fiber optic, and my decision to use the fiber optic, it's familiar for me. use oral fiber optic for intubation, and they railroad your endotracheal tube on it. But please insert nasal fiber optic so you can visualize your tube while railroading in the oral fiber optic. Is it complicated? No, it has been published in before. In 2011, they use a second fiber optic bronchoscope through the nasal route to guide the oral fiber optic intubation in 2 patients with existing vocal cord injury. They wanted to avoid hitting the injured vocal cord, so they put nasal fiber optic to show them the whole vision. Put their oral fiber optic railroad the endotracheal intubation, or you can, I think you can make like a combination between the video laryngoscopy, the same like nasal fiber optic to visualize the whole view, and oral fiber optic, use it as if it's convenient for you. So our home message, if you are confronted with a patient with vocal cord implants, please remember this slide. You should use the best fit endotracheal tube by measuring the internal diameter of trachea by ultrasound or CT neck. The intubation, ask for help of airway expert anesthesiologist. Always use the video laryngoscopy. Do smooth induction. For lung isolation, we recommend to use single lumen tube and bronchial blocker, not double lumen tube. In difficult intubation, use video laryngoscopy. If you are convenient with fiber optic bronchoscope, please put another nasal one for visualization. At extubation, deep extubation is recommended. If it's not, please replace the endotracheal tube with the laryngeal mask airway and put the fiber optic through it to check the implant. If it's good, it's good. Displaced or migrated, ask the attending laryngologist to fix it. The references is our article about challenge of lung isolation in patients with vocal cord implants, which has been published this year, early in February, in the Anesthesiology and Pain Medicine Journal. Thank you.
Okay, thank you very much, Dr. Islam. And just some questions. The co-authors with you from which hospital, which country?
There are two groups. The first one in the Red Journal of Cardiothoracic Vascular Anesthesia was our team in Ohio State University. The second, this was the case report. About the article, it's a different Dr. Amir from from private hospital in California, and I think Dr. Omar is a professor of pain and anesthesia in Louisiana State University.
All right, yeah. Just I want to ask, what is the frequency to see a patient with vocal implants? For me, 34 years, I never saw it.
For this reason, the Journal of Cardiothoracic Anesthesia, which is the top of cardiothoracic, accepted the case report because it is the first time to report that one, and it's very important because there is a medical legal issue. The patient will lose his voice.
It is pediatric or adult patient usually?
Adult. All of them are adult.
Yeah, all
and
right.
Because it's rare, we reported.
Yeah. How many cases you saw in your experience?
Not more than that case.
Yeah.
But sir, the cause that the otolaryngologist not use this, not offer the patient this option, and it's it started just in 1974 and started to increase. So I think we will be confronted with these patients more and more in the future.
Yeah. Actually, it is very interesting. Yeah. Thank you very much.